हाउ टू स्कैन गॉल ब्लैडर का स्कैनिंग कैसे करते हैं अल्ट्रासाउंड में डॉक्टर वकील अहमद MPT ऑर्थो द्वारा बताया गया है।
Hi everyone, my name's Adriana and I'm one of the sonographers at the University of Auckland. Today we're going to be learning about how to scan the gallbladder. We have our lovely volunteer Bruce who is going to be acting as a model for us to scan. So what we are going to do is we are going to get our gel and we are going to make sure that the tip of the bottle does not touch the patient. So Bruce, just some warm gel here. We're going to apply a generous amount. In order to start the scan, I'm actually going to use my curvy linear probe, and I'm going to start just by trying to find the gallbladder. So the way that we can find our gallbladder is first by identifying the portal vein. So Bruce, can I get you to take a big breath in? And I'm going to find my portal vein. So here's my right portal. As I sweep inferior, the gallbladder appears anterior. I'll then adjust my depth and my focus and breathe. So the first thing that I'm going to do is start my sweep in transverse. So a big breath in for me. Good. And hold that breath. And I first am going to come into the neck. And then I'm going to be moving my way into the body all the way out through the fundus. And I go all the way back down until I'm fully out of the gallbladder and breathe. Good. I'm now going to find the longitudinal plane of the gallbladder, and I want to make sure that I have it fully elongated. So again, a big breath in, and I'm angling through that liver to try and get rid of any of the reverb that I can see in the fundal portion of the gallbladder. I might have to adjust my TGC or my overall gain to make sure that the gallbladder looks nice and anechoic. And now I'm going to sweep all the way out to the patient's right, all the way to the patient's left, and I'm going to come back to midline. Good, and breathe. While we assess the gallbladder, we're making sure that we don't see anything shadowing within the gallbladder and that the wall is smooth and that there is nothing focally thickened along the gallbladder wall. Now I'm ready to take my pictures. So the first thing that I'm going to do is actually take a dual screen image of the neck and the fundus. So again, when you're ready, a big breath in. I'm going to hit the dual screen button. And on the right, I'm going to take an image of the gallbladder neck. So we come here. I change my depth. I make sure my focus is just posterior to the gallbladder. And then I'm going to update, my screen. Like that, breathe normally. Now I'm going to get ready and move down towards the fundus. Big breath in. And see how I move my transducer inferiorly, the fundus is moving more anteriorly. And we want to make sure that we have a really nice place where we can measure the wall and prove that it is nice and thin. So about there where I can feel quite confident, breathe normally, I can see the borders. When I annotate, I'm going to make sure it says trans gallbladder, and I am going to annotate the position which my patient is in, which is supine. That's because the patient position is going to change the most dependent portion of the gallbladder. So on the left side of the screen, we have the neck. And then over here, I'm just going to write fun for fundus. I'm going to take an image, and then I'll take one other image with calipers. When we measure the gallbladder, we're going to go from the echogenic line to the echogenic line. And his gallbladder wall is only measuring 1 millimeter, which is well in the normal range. The next thing that I'm going to do is take a longitudinal image of the gallbladder, a big breath in. And again, with him in supine, the most dependent portion of the gallbladder is the gallbladder neck. So I really want to make sure that I demonstrate that the neck is completely normal and that there's no stones within it. I can freeze the image there, breathe normally. I'm going to annotate my screen to make sure that it says long gallbladder, and then again I'm going to annotate supine. It's also important that when we assess the gallbladder, we assess to see if there is a positive Murphy sign. So what we can do is we can go live, and you want to make sure you are not on the patient's ribs. So we're going to be in a subcostal window looking at that gallbladder. Take a nice big breath in. And in the transverse plane, I'm now going to apply a bit of pressure over the gallbladder, and I'm doing this while I'm live scanning. Breathe normally. Now, Bruce, when I apply pressure here, do you feel any pain?
No.
Good. So that means that he has a negative Murphy sign. All good. The next thing that we need to do when we assess the gallbladder is assess it in a different patient position. So supine and left posterior oblique mean that our neck is going to be the most dependent portion. When we turn our patient into decube or have them erect, the fundus will now become the most dependent portion. So can I just get you to turn all the way onto your side so that you're facing the wall away from me? Good. And now just scoot your body back so you're closer towards me on the edge. Good. So again, even though I didn't see anything while I was scanning the gallbladder with the patient in supine, it's important that we assess it in two planes, because if there is anything mobile in there, we'll be able to see it. When you're ready, Bruce, a big breath in. Good. And we are going to sweep through that gallbladder and lung all the way out of the borders. Breathe normally. And what I'm going to do is just lower the bed a little bit so my shoulder can be at a more level angle here. And now I'm going to go in transverse, a big breath in, and I'm going to start superior to the gallbladder. So again, finding that portal vein, and I sweep all the way through, and I change my depth. Oh, this is as much as I can change it. And breathe. And now we can image us again, and we are going to do a dual screen. Big breath. We can go in transverse here of the neck, and we go all the way up towards the fundus, making sure that the liver does not appear as anechoic as the gallbladder. Breathe. And we can annotate so that it says trans gallbladder, and we need to actually change that so that it says LLD, which stands for left lateral decube. We'll annotate here neck. We'll come over to the other side and write fundus. And now, because we checked for a Murphy sign, we can write non-tender. We'll take that image there. And now I'm going to get my annotation ready for that next, the next image, which is going to be in the longitudinal plane. You can get rid of that. And we'll hit long. We'll clear screen, long, gallbladder, and LLD. Sorry guys, sometimes our machine doesn't work the way we want it to. Long, gallbladder, LLD. There we are. Big breath in for me when you're ready. Good. And again, really showing that that fundus is completely clear and that there is nothing that is moved. My focus is just at the posterior level of my gallbladder. Good, and breathe. Now we can go and take a look at that bile duct, which we expect to see just anterior to our main portal vein. To make sure that I'm seeing the gallbladder, the bile duct, I'm just going to use color Doppler. Because it's going to be filled with bile, I don't expect there to be any flow within it. And then I will change my zoom. And what I'm doing now, because I'm live scanning, I'm changing my right zoom. So big breath in. Good. Hold that breath. There we are. Good. And breathe. So you can see this tubular structure here, which is my bile duct. So I can clear my screen there, and I can annotate common bile duct. And I'm going to make sure that I measure without color Doppler on, and that's only because my resolution is not as optimal with color on. So here I have my image of my bile duct, and when we measure, we're always going to measure at the widest portion. What is great about Bruce's bile duct here is that we can actually see it tapering as it enters into the pancreatic duct. So I'll take 2 measurements showing that it is completely normal. The first measurement was 3.5 millimeters, which is well below norm, or the upper limit of normal. And then it tapers down to 2.3 millimeters. Again, completely normal. And that is how we image the gallbladder and bile duct.